So imagine going into surgery, right, to fix a really painful, severe pelvic prolapse. You endure the whole operation, you go through the recovery, and you wake up, and you are completely cured of the prolapse itself.
Which is, the ultimate goal.
Right, exactly. But then suddenly you realize you need adult diapers. It's one of the most frustrating, just mind-bending paradoxes in modern medicine.
It really is. It's this wild concept that sometimes a severe physical problem is actually acting as, well, like a bizarrely effective bandage for a completely different hidden issue.
Yeah, and welcome to this deep dive. Our mission today is to unravel exactly that, why surgically fixing a pelvic organ prolapse, or POP, can suddenly cause a woman to experience stress urinary incontinence, even if she, never ever had a leakage problem before.
And to answer that, we are synthesizing a pretty massive stack of complex medical literature today. We're pulling from the clinical trial protocols of the CARE, OPS, and Cupido trials.
Some heavy hitters in the field.
Oh, absolutely. And we're also looking at the latest guidelines from the AUA and SUF, plus we are digging into the mechanics of the integral theory and even some surgical quality measures from CMS.
Right, so the ultimate goal here is to really change how you think about the human body. Because, we usually assume the body is like a car engine.
Right. If a part falls out of place, everything stops working.
Exactly. But the epidemiology data from these sources points to a totally counterintuitive reality. Like, up to half of women with pelvic organ prolapse have coexisting stress urinary incontinence, or SUI.
Right.
But as the prolapse gets more severe, the incontinence symptoms actually decrease, which is wild. You would assume a worse prolapse means worse symptoms across the board.
You would think so, yeah. But the anatomy tells a completely different story. To understand why a severe prolapse seems to magically cure incontinence, we really have to look at the mechanical forces inside the pelvis.
Okay, lay it out for us.
Well, the foundation here is the hammock hypothesis, which was originally detailed by a researcher named Delancey back in 1994. Under normal, healthy circumstances, continence relies on the urethra being structurally supported from underneath.
Like a literal hammock.
Exactly. So think about what happens when you cough or laugh or bear down.
Your intra-abdominal pressure spikes.
Right. That pressure pushes down on the bladder and the urethra, and if the anatomy is intact, that downward force pushes the urethra directly against a supportive layer of tissue underneath it, which is the anterior vaginal wall.
Oh, I see.
So the urethra basically gets compressed shut between that downward pressure and the supportive tissue. It's this dynamic physical closure entirely dependent on having a solid backstop.
So the vaginal wall basically acts like an anvil, and the downward pressure is the hammer. Urine from leaking.
When things are healthy, yes. But in advanced prolapse, specifically a cystocele, which is, when the wall between the bladder and the vagina weakens and the bladder drops, the whole anatomical neighborhood shifts.
Right.
The dropped bladder actually slips under the bladder base and down past the urethra. Now, when a woman with a severe prolapse coughs or strains, that spike in abdominal pressure doesn't just push down on the urethra.
What's it do?
It pushes that massive dropped cystocele further out.
Okay, let me make sure I'm visualizing this mechanical shift correctly.
Mm-hmm.
Because reading the sources, I couldn't help but think of, like, a garden hose.
Okay, I like that.
Let's say you have a hose with a tiny hole in it. That hole represents a weak urethral sphincter. Every time you turn on the water or, every time this patient exerts physical pressure, water leaks out.
Right, classic stress incontinence.
But then a heavy rock rolls right onto the hose and completely kinks it in half.
Yeah.
That heavy rock is the prolapse. Suddenly, the leak stops. You look at the hose and you think, oh, the leak is cured. But the hole is still there. The increased pressure from the prolapse is just kinking the tube shut.
Creating what the medical literature actually calls a functional outlet obstruction. The prolapse is literally the rock kicking the hose. The body is essentially using the displaced organ to clamp down on the urethra.
Which sounds great until you try to fix it.
Right. The inherent danger of that rock is what happens when a surgeon decides to remove it. When clinicians go in to fix a POP, their entire goal is to restore normal anatomy. So they lift the bladder back into the pelvis, they reinforce the vaginal walls, they suture the connective tissues.
They remove the rock, and the second you unkink that hose, the hidden leak just comes rushing back.
Exactly. The underlying weakness of the urethra, which was, present the whole time but physically blocked, is exposed. Without the mass of the prolapse obstructing the flow, The patient starts leaking urine during physical exertion.
And there's a specific term for this, right?
Yeah, the medical term is occult stress urinary incontinence, or OSUI, occult just meaning hidden. And the prevalence is staggering. Up to 80% of women with advanced prolapse might have this hidden incontinence just waiting to be unmasked by a supposedly curative surgery.
Yeah, up to 80%. So because fixing the prolapse unmasks the leak, surgeons must be terrified of operating blindly. They have to figure out a way to see the leak before they make the first incision.
They do, yeah.
But I'm kind of confused here. If the prolapse is completely burying the leak, physically kinking the hose, how can a doctor possibly test for it without just doing the surgery and hoping for the best?
Well, that is the ultimate diagnostic puzzle. Clinicians use something called urodynamic studies, or UDS, combined with prolapse reduction.
Okay.
The goal of this testing process is to artificially mimic what the patient's internal anatomy will look like after the surgery is actually finished.
Good.
So, to do this, the clinician fills the patient's bladder with fluid, and then they use a physical tool to artificially push the prolapsed organ back up into its normal elevated position inside the pelvis.
Right, so they are manually unkinking the hose right there in the exam room.
Yeah.
And the sources list a bunch of different tools they use for this artificial reduction, right? Like large cotton swabs, ring forceps, a split speculum, or a pessary.
Exactly. They basically hold the prolapse out of the way and then ask the patient to cough or bear down heavily. If leakage occurs during this artificial reduction, but stops when they let the prolapse drop back down, they've successfully diagnosed occult stress urinary incontinence.
They found the hidden leak.
Right.
But looking at the data from the CARE trial, which was this massive landmark randomized surgical trial dealing with abdominal sacral pulpopexy, there is a fascinating, almost alarming discrepancy in how this testing plays out in the real world.
Yes, absolutely.
The diagnosis completely changes depending on the specific tool the doctor uses to push the prolapse back up. Well, that blew my mind.
It highlights one of the most critical, delicate nuances in all of pelvic medicine.
Because the trial data showed that when a doctor used a pessary, which is, a removable device inserted into the vagina to hold the organs up, only 6% of the women showed any leakage during the test.
Right.
But when the doctor used a split speculum instead, 30% of the women suddenly showed leakage.
That is a massive diagnostic swing.
It's huge.
If I'm the patient, my diagnosis literally depends on which tool the doctor happens to pick up off the tray. So why is a passive piece of silicone, like a pessary, completely skewing the test and hiding the leak in 94% of these women?
Well, the problem is that a pessary is not a passive piece of silicone. A split speculum is essentially neutral. It just moves tissue out of the way. But a pessary is designed to provide structural support to the entire pelvic floor.
Oh, I see.
So when a clinician inserts a pessary for this test, the device actually increases the maximum urethral closure pressure. It also physically increases the functional length of the urethra.
Wait, really? Yeah. So by its very design, it is actively treating the incontinence at the exact moment the doctor's trying to test for it.
Wow. So the tool meant to unmask the leak is acting as a temporary plug itself. It's creating this massive false negative. The doctor looks at the test, sees no urine leaking, and thinks, great, the hose is structurally sound, we are clear for surgery. But it's only because the testing tool itself is clamping the hose shut.
And this just illustrates the immense difficulty clinicians face. Even our best, most standardized diagnostic tests can inadvertently alter the local physiology of the pelvis. Testing a system inherently changes the system.
Yeah, it's like quantum physics, but for urology. Okay, so let's assume the doctor navigates this perfectly. They avoid the pessary, they use the speculum, they correctly diagnose the occult incontinence, and they plan the surgery.
Okay.
The literature shows us that unmasking a hidden leak is only half the battle. Because sometimes there is absolutely no pre-existing occult incontinence at all. The patient is truly functionally continent. The hose does not have a hole in it. Yet after the prolapse repair surgery, they start leaking anyway.
We call this de novo, or new onset, stress urinary incontinence. And the incidence rates are not small. The clinical data reports this happening in 10 to 25% of prolapse repair cases.
That is terrifying.
It is. The patient enters the operating room with a healthy, intact continence system, and the surgeon accidentally creates a leak by fixing the prolapse.
But how? How does fixing a broken structure end up completely ruining a healthy function?
To grasp this, we really have to move away from visualizing the urethra as a simple plumbing tube. We need to look at the integral theory, which was heavily researched and developed by Dr. Peter Petros.
Okay, the integral theory.
Yeah. It posits that urinary continence does not rely on a static, rigid structure. Instead, it relies on a highly synchronized, delicate balance of muscle forces and tissue elasticity, specifically at the bladder neck.
Right.
Petros actually calls this the zone of critical elasticity.
There is an analogy for this zone of critical elasticity in the sources that made this instantly click for me.
Oh, yeah. The trampoline one.
Yes. Think of the entire pelvic floor as a trampoline. The vaginal membrane is the trampoline mat itself, and the pelvic ligaments are the metal springs connecting the mat to the outer frame.
It's a perfect way to visualize it.
So when the three distinct muscle forces of the pelvic floor contract, they pull against those ligament springs, stretching the vaginal membrane tight to support the bladder base and close the urethra.
Right, it's a dynamic action. It absolutely requires the tissue to bounce and stretch, just like a trampoline mat. That elasticity is totally non-negotiable for continence.
Okay.
The muscles need the freedom to pull and stretch that vaginal tissue to generate the closure force against the urethra.
So if a surgeon goes in to fix an apical prolapse, say, using a procedure called a laparoscopic sacrocolpopexy, where they use a synthetic mesh to lift the vaginal vault back up and attach it to the sacrum, they are fundamentally altering that trampoline.
They are.
And if they pull that synthetic mesh too tight during the repair,
They completely destroy the elasticity of the pelvic floor.
wow. It's the equivalent of taking a bouncy trampoline spring and replacing it with a rigid, immovable steel rod.
Exactly.
The patient goes to cough, the pelvic muscles fire, they try to pull the trampoline mat tight to close the urethra, but the steel rod won't give. The tissue just cannot stretch.
The zone of critical elasticity is compromised.
And so the muscles can no longer manipulate the tissue to close the urethra properly, and suddenly, boom, the patient has de novo stress urinary incontinence.
Right.
The mechanics of the surgical cure introduced a brand new structural failure by making the system way too rigid.
And, a retrospective analysis published in the Journal of Clinical Medicine actually confirms the danger of that steel rod effect.
What did they find?
Well, researchers looked at over 200 postmenopausal women undergoing surgery for apical prolapse. They found that laparoscopic sacrocolpopexy, that exact procedure that utilizes the synthetic mesh lifting technique, was associated with a 10-fold higher risk of postoperative stress incontinence compared to other procedures that only use the patient's native tissue.
Wait, tenfold?
Yeah, the odds ratio was 10.37.
That is massive.
Yeah.
A tenfold higher risk completely flips the narrative of what a successful surgery even looks like. You aren't just uncovering a hidden problem. The tension of the repair is actively manufacturing a new one.
Which is incredibly frustrating for everyone involved.
I mean, this completely explains why some women who never leaked a single drop during their rigorous pre-surgical urodynamic testing suddenly require thick incontinence pads after a textbook prolapse repair.
Right.
The surgeon perfectly fixed the structural sagging, but inadvertently ruined the dynamic function by over-tensioning the tissue.
And it forces us to ask what the patient should actually do with this information, right? If you, or maybe a family member, are facing pelvic organ prolapse surgery, you are standing at a very complicated, high-stakes medical crossroads.
Which brings us to the clinical trials trying to solve this surgical conundrum,
Yeah.
most notably the OPS and Cupido trials.
Exact.
Because doctors know about the king toes effect, right?
Yeah.
And they know about the trampoline tension, so they have to decide how aggressively to treat a patient in the operating room.
Yeah, and the Cupido trials were designed specifically to test two distinct surgical strategies for patients who have both a prolapse and a diagnosed occult stress incontinence.
Okay, what are the strategies?
So strategy one is the combo approach. The surgeon goes in, fixes the prolapse, and during the exact same operation, proactively performs a continence procedure.
At the same time.
Right. Usually this means installing a mid-urethral sling. It's a small strip of synthetic mesh placed under the mid-urethra to act as a permanent backstop, basically preventing the incontinence from happening once the prolapse is gone.
Okay, and strategy two is the wait-and-see approach. The surgeon only fixes the prolapse. They completely leave the urethra alone. Then they basically wait to see if the patient actually develops incontinence in their daily life.
Right.
And if they do, they eventually go back in for a second, totally separate surgery to place the sling.
And both of these options carry heavy, life-altering realities.
Imagine.
If a surgeon opts for the combo surgery, they dramatically reduce the risk of the patient waking up with postoperative leakage. I mean, the CARE trial showed that proactively adding a Boch-Colpo suspension, where they suture vaginal tissue to ligaments to elevate the bladder, neck-reduced postoperative SUI by half.
Okay, so you fix the prolapse, you preemptively fix the unmasked leak, and the patient only endures one surgery and one recovery period. Sounds like a win.
It does, but the cost of that convenience is the increased risk of severe complications.
Like what?
Well, a mid-urethral sling or a Birch-Colpo suspension, these are not benign additions. They are major anatomical interventions. Putting a sling under the urethra can lead to obstructive micturition, which is this terrifying condition where the patient physically cannot empty their bladder.
Wow.
Yeah, or it can trigger severe overactive bladder symptoms. Furthermore, the diagnostic tests, as we established with the pessary and speculum data, are highly flawed.
Right, the false negatives.
Exactly. Even with the best, most rigorous urodynamic testing, a significant percentage of women diagnosed with occult SUI in the exam room will never actually develop real-world leakage after their prolapse repair. Their bodies simply adapt.
Meaning, if you automatically perform the combo surgery on every single woman who shows a leak during testing, you are essentially treating a ghost.
Exactly.
You are subjecting a woman to a continence surgery and risking her ability to ever pee normally again
Yeah.
for a leak that was never going to materialize outside the hospital.
And that is the profound surgical conundrum. Do you risk overtreating the patient to guarantee dryness, or do you risk undertreating them?
And the toll of undertreating, the wait-and-see approach is devastating in its own right.
It really is.
Just imagine the psychological distress. You undergo major prolapse surgery. You wake up, the heavy, dragging sensation in your pelvis is finally gone. You go home feeling totally relieved.
Right.
A week later, you sneeze and you completely wet your pants. And because of surgical healing times, you might have to wait 3 to 6 months living with severe incontinence before a surgeon will even agree to open you back up, put you under anesthesia a second time, and install the sling.
Which is why this requires a deeply nuanced, incredibly honest conversation between the clinician and the patient. Shared decision-making isn't just like a clinical buzzword in pelvic reconstruction. It is the absolute foundation of ethical care. The patient has to weigh their own personal tolerance for risk. Are they more terrified of the emotional and physical toll of waking up leaking and needing a second surgery? Or are they more terrified of a permanent complication like urinary retention from an unnecessary sling?
It's a brutal choice.
Yeah.
But the medical system at the highest levels is finally recognizing how vital this pre-surgical assessment actually is, right?
Mm-hmm.
The Centers for Medicare and Medicaid Services, CMS, actually stepped in and established a specific quality measure for this exact scenario.
Yes. Measure number 428.
Right.
Measure 428 mandates the preoperative assessment for occult stress urinary incontinence in women undergoing anterior or apical prolapse repair.
Meaning, the federal government is literally grading doctors and hospitals on whether or not they are proactively checking for this kinked hose phenomenon before they ever pick up a scalpel.
Exact.
If a surgeon just blindly fixes a prolapse without testing for the hidden leak, their quality metrics take a hit.
Because without that assessment, informed consent is an illusion. A patient just cannot legally or ethically consent to the risks of a surgery if no one ever sat them down and explained that lifting their drop bladder might suddenly unmask a hidden leak, or that tensioning the mesh might destroy their pelvic elasticity.
Wow. Let's take a breath and just recap the incredible mechanical journey we've been on today.
It's a lot to take in.
It really is. We started by exploring how the human body compensates for failure, how a severe pelvic organ prolapse can actually act as a structural band-aid, hiding a leaky urethra by kinking it shut under the massive downward pressure of the abdominal cavity.
The heavy rock dropped on the leaky garden hose.
Right. And then we look at the diagnostic detective work and how surgeons use urodynamic testing to try and find that hidden leak by artificially pushing the prolapse out of the way.
Right.
But we also saw the physics traps hidden in that testing, where tools like a structural pessary can artificially compress the urethra, treat the leak during the exam, and give a disastrous false negative.
Yeah, a massive challenge for doctors.
And then we ventured into the de novo dilemma, uncovering how a perfectly healthy continence system can be destroyed by the prolapse repair itself. By pulling synthetic mesh too tight, surgeons obliterate the delicate zone of critical elasticity.
Right. They replace a dynamic, bouncing trampoline spring with a rigid steel rod, leaving the pelvic muscles entirely unable to stretch the tissue and close the urethra.
It just reinforces that the body is not just a collection of static parts you can unbolt and bolt back together. It is a highly dynamic, elastic system.
Absolutely.
Which brings us to the ultimate surgical conundrum facing patients today. Whether to proactively add a sling to prevent the unmasked leak, risking severe overtreatment and urinary retention, or to wait and see, risking the heartbreak and physical toll of a second delayed surgery.
It is a delicate, high-stakes balance of mechanical risks, requiring deep patient advocacy, rigorous testing, and a profound anatomical understanding.
Which is exactly why we do these deep dives into the literature. But before we sign off today, I want to leave you, the listener, with a brand new concept to ponder.
Okay, let's hear it.
Something that builds on all the incredible anatomical compensations we've talked about today. Think back to the initial paradox.
Right.
The human body can naturally, albeit completely accidentally, kink the hose to perfectly stop a urinary leak by utilizing the downward pressure and weight of a prolapsed organ. It's a crude, physical solution to a muscular failure.
The functional outlet obstruction.
Exactly. So, if that accidental kinking is so incredibly effective at keeping a woman continent, could future non-invasive bioengineering figure out a way to artificially recreate this exact, precise, protective kinking effect?
Oh, that is fascinating.
Right. Could we bioengineer a tiny internal mechanism, perhaps, like an adjustable suburethral balloon or a smart tissue implant that perfectly mimics the protective downward pressure of a prolapse, but without the negative, uncomfortable, dragging side effects of an actual falling organ?
That would completely change the field.
Imagine a future where the ultimate cure for stress incontinence isn't cutting into the vaginal wall to pull mesh tight or aggressively anchoring slings to pelvic bones. What if the cure is simply mimicking the very condition doctors are currently trying so hard to cut away? Just a perfectly placed microscopic artificial rock on the hose. Think about it.